Many of you may know him as one of the WHO medical officers in India who was a key player in the final days of the smallpox eradication campaign. One of the things that you may not know is that after smallpox, Larry founded an organization that has had probably similar impact, the Seva Foundation, which has restored sight to over 10 million individuals since that organization has been founded. In the 1980s, Larry got involved in the early days of the technology revolution. He's been a leader in that space, especially on the social good side of things since the 1980s. He actually founded one of the first social network companies. It's still in existence. It's called The Well, and was the inspiration for many social network companies and organizations that came after. He was the first head of Google.org and vice president of Google in that capacity. I'll say more about this later, but while he was at Google.org, he led the development and launch of a tool called Google Flu Trends, which in many ways laid the foundation for the field that Dr. Blumenthal has called for in public health technology. He's been the CEO of Skoll Global Threats Fund and served on the boards of Salesforce.org, Skoll, and Google Foundations. And I'm listing these in part because I want you to understand what an amazing honor it is to have him here, but also because Larry has been a part of funding and bringing to life tools in public health technology throughout his career. During the pandemic, he was a CNN medical analyst, wrote for the Wall Street Journal and many other venues, advised WHO and government organizations, and founded a group called Pan Defense Advisory. Today, Larry, among many other things, is the founder and CEO of an AI startup called Eviti, that works at the intersection of epidemiology and health span with its mission to combine the best medical science and AI tech to create products that increase years of healthy longevity. So not just lifespan, but health span for all. So as I mentioned, it's truly a pleasure to have Larry here. I've been very fortunate to call him a mentor and friend for almost 10 years now, and I'm excited to have him share his wisdom and experience with all of you. So, Larry, do you want to say anything before I ask you a few questions, or do you want me to just start asking, although you're on mute?
I do. I want to say right back at you. It's been a pleasure. It is a pleasure. We're currently working together, working with you, Sam. You have taught me so much and been a friend and a colleague, and we will continue that relationship. For those who don't know, the Institute for Experiential AI meets up every one of those words, Institute, Experiential, and AI. And my company has been working with them to help develop some innovative AI-assisted tools to help us with helping people to get to maximum years of health span that they can get from their individual lives, and then in the aggregate for their community, for their country. And Sam, we couldn't do it without you and without that big guy, Usama, who I got a bromance with when I found out that he had 4 engineering degrees from the University of Michigan, which is where I was a professor, my alma mater. I don't think we can talk about anything. We have a really wonderful set of questions that you and I are going to talk about. We can't not mention the elephant in the room, because everybody you know has experienced a drop in your 401k, but more poignantly and more importantly than that, over the last 5 days, I've received double that number of phone calls from people who've been fired, let off. 2,500 people at CDC, including a lot of young EIS officers who are the cream of my profession, the great disease detectives. Many of them had just been deployed to new states with their families, bought a house or rented a house, moved, and they're left adrift in that new place without sometimes even the money to fly back home. The pullback from funding research institutions that we've seen, the double whammy of decreasing overhead and at the same time targeting individual universities, the putting in place the people who lead us in vaccine, who are anti-vax, who lead us in science, who've not shown a pro-science life history. It's hard not to mention those things. On the other hand, we can't do anything about this individually. I'm reminded often that because we have a project on climate change and health and wildfire and health, that when a wildfire goes through a forest, it burns down all the tallest trees. And then the young shoots have a chance to sprout and begin anew again with renewal. And I was just at Daniel Kraft's NextMed, and you meet all these young people who have great innovative ideas and products. And for them, this is just the beginning. And you can't help but feel inspired by what they're doing. So you have to balance those two things, I think. And that's I think that's the background for our conversation.
Oh, thank you for saying that, Larry. And I also appreciate the inspiring message at the end. I think especially there are a lot of young people that are trying to understand what they should be doing now, and especially in the space of public health. And I think one of the hopes is that technology will excite new kinds of innovators to come into our field. That's certainly one of the things that Dr. Blumenthal and her colleagues have written about so eloquently. We can maybe go back to smallpox a little bit later, but one of the first time I ever saw Larry's name was on the Google Flu Trends paper that was published almost 20 years ago now. And for those of you that are unfamiliar, the team at Google and google.org used machine learning to mine Google searches and construct a time series that was very highly correlated with influenza activity in the United States. And for many people, this was one of the first big papers in the field that became computational epidemiology, that inspired a lot of the forecasting work that is happening at Northeastern. And there are folks like Professor Mauricio Santillana that's on the call that have continued that kind of work, advancing from where Larry and the team were. But what I want to ask you about, Larry, is I'm sure that it wasn't, maybe it was easy, but I'm sure that it wasn't easy to convince Google that you should do this and that it was going to be impactful. And, why would we even want to have a time series for influenza activity? And so maybe you could tell us a little bit about the sort of leadership tactics and change management that you used, and maybe how that might relate to some of the stuff that we're trying to do in this new field of public health tech.
And some of our failures too.
Yeah.
I'll go back in a second to how difficult it was to get it started. It was much more difficult to get that paper, which was in Nature. And after we had run it for 3 years, 1 year with nobody knowing, so we could test that this crazy idea that if we took every single keystroke ever entered into Google, and if we did something like 100,000 simultaneous multiple logistic regressions on something approaching 10 million individual computers networked all over the country, and the largest, probably the largest data crunching exercise, because you have to do it in real time every minute, that had been done up until then. And after we had run it 1 year and it worked, but remember, if you ever built a house, it seems crazy, and you built a deck, you're told by the building authorities you can only cantilever it out a certain number of feet relative to the span of the house. And so we had cantilevered that model out from truth data, which was CDC's ironclad truth data, because it was based on patients who had the sniffles or a cold. They go to see their doctor. The doctor sends them home. They come back again. He says, well, maybe we ought to get a test. They take a specimen. They send the specimen to the lab. The lab gets it, forgets about it for a day, and then reports it back. So there's a 2-week lag in CDC's data, and we exploited that 2-week. Well, we tried to close that 2-week gap by anticipating, by taking our model and cantilevering it out so that we could then beat CDC's reporting data by 2 weeks. We could predict, forecast where the next case of seasonal flu was as a surrogate for the inevitable pandemic that we expected, and this was 2005. And what began it was a talk I gave at TED when I got the TED Prize, and with the TED Prize then it was $100,000. My timing was bad. Now it's $150 million. But the TED Prize was a prize for you to do something good with the money, not buy a Mercedes. What I wanted to do good was set up a sentinel system, forecasting system to forecast against pandemic and other bad things in public health that would happen. So when we had finished the third year, the first year we really felt comfortable, I went to Larry Page and it was in the OM committee, the Organizational Management Committee, which was Larry and Eric and Sergey and Cheryl and me. And I went there and I said, I want to publish this in Nature. And Larry said, why would you want to publish it? We're only a couple 100,000 people would see it. Publish it on the Google front page. We'll get 2 billion people to see it. I said, no, Larry, to be credible, you have to have peer review. You have to send it through the scientific. And he thought that was, that the idea was to get the most exposure to it. And he was pushing for that. And I was secretly negotiating with Nature. And Nature said, sure, we'll be happy to look at it, but can you tell us another lab where we can duplicate your results? And I said, I hate to break it to you, but there is no other lab. At that time, Google's computing capacity exceeded that of NASA. So in the end, we did publish it, and it urged the use of these kinds of tools in public health. These tools are reserved now for business to predict what revenue and profit's going to be in order to give comfort to investors. I want to give comfort to the public health. So we built it. And for the next 2 years, it was unerringly positive. You could live in a small community in rural Iowa, and that model would tell you where the next case of flu would be. It led to John Brownstein and Mark Smolinski, who was working for me, to build something called Flu Near You and then COVID Near You, and that whole idea of crowdsourcing of information to replace the keystrokes in Google. And that picked up. I think that was a very credible way to use a far less expensive intervention. But then I left Google, and Mark was still there. And then the 2 engineers who had really done the major work and were the lead authors of that paper, they left Google. And then Mark left to come work with me at Skoll. And Google stopped its interest. And it was, up until then, they were carrying it was a very costly endeavor. And Google was bearing the expense. And so they did an experiment to see how far out it could be cantilevered, and it actually crashed. It lost its way. And then while Google had gotten all this credit in the beginning, and we had gotten all this credit, none of us were there to protect it or to explain why you can only cantilever an epidemiological model out so far. And I think that's where I'll leave it. But the lesson is to know how far you can cantilever it out. For how far in the future can you use the past before you're reminded of what every investor is told, that the past is no guarantee of the future.
Actually, I think it was Professor Alex Vespignani, who's on the call, along with Professor David Lazar in Network Science Institute of Eastern, that actually wrote about how Google had over cantilevered itself with respect to Google flu trends and some of the lessons. But I remember at the time when we were all going through that, one of the things that we were really praising Google for is that we were able to evaluate what was going on because the data were made available in a way that researchers could check and evaluate it. It probably wasn't fully open, but it was one of the more open tools that were there, and that this was something that we didn't have at the time in the sciences as much, and we have made a lot of progress on. But there was another aspect of that, which is the importance of having something out in the open for people to build and innovate on top of. And I think that was one of the other outcomes that came from that Google Flu Trends tool.
Yeah,
what kind of innovation happens?
Google was great about that. And actually everything was out in the open except for the secret 50. And let me mention, because I didn't get into it, but what were all those multiple logistic regressions about? What's the purpose of finding every keystroke? It was to start with the billions of keystrokes and resolve them down first to 1,000 and then to 200 and then to 100 and then to enough keystrokes that you could explain 99% of the predicted location of the next case of flu, but could be done with a very small number of targets. So we got down to 50 from all those billions of keystrokes, 5 years of all the Google data, hundreds of billions of keystrokes a day in the latter years. and we found the 50. And we didn't feel we should publish that, not because it was a secret, but because we thought if people had it and they used it and they got results that weren't based on our gold star data, that they would really take people astray. But the intent was to be totally transparent and open source about that. And I really credit Google for that.
No, that was very important for the community, both in terms of what it inspired with more open source, but the sort of opportunities that it opened up. Switching gears a little bit, as I mentioned in the introduction, you spent a lot of time funding social impact tech or overseeing the organizations that fund social impact tech. And we know one of the big challenges for this new field of public health technology is going to be bringing in new and diverse kinds of funders who are interested and willing to support this. And would love to know sort of any thoughts or ideas you have about, how we make this field attractive for diversified funding. What do you think those funders are going to be looking for? Who might some of them be? Any advice that you have there?
Well, I think you steered us in that direction, because just as I was getting on and getting set up, the last words I heard from you is if there's anybody on this call who wants to fund these things, to let you know. So I think you've struck it rich. There's going to be incredible pressure on funders with cutbacks and overhead, and some universities being targeted, and research departments being hollowed out, and the number of people who are looking for jobs right now who 5 minutes ago were star researchers that you would have put on your grant. It's going to be more difficult. It seems like anything that has the word vaccine in it is toxic right now, which is inexplicable to somebody who saw the last case of smallpox, a disease that killed 500 million people in the 20th century and was only ended because of a vaccine, and measles, polio. I mean, the list is very long, but that is where we are right now. So there's going to be pressure on funders. I would encourage people. I also heard, I thought the dean used the word productize, which is an unusual word in public health, but I liked it, because the more you can productize the work you do and to spin it off into industry, and follow the model of MIT and Michigan, and own some equity in the companies that are started, if you can do that, if your charters allow you to do that, the more you'll become self-sufficient. And there are so many breakthroughs that we will do in public health that will be applicable to commercial uses, probably not in public health, but outside of public health, whether in clinical medicine or in med tech, or even in unrelated fields we haven't thought of. And it's hard to say this to a young person who's coming from pure intentions, research only, which I think all of us either are or were at one point in our time. Keep one eye on the funding and make sure that what you're doing is proven to be good, not just in some theoretical future, but in the present, when you look at what the market acceptance of it is. The foundations, I hope that we can commit them to erode their corpus, their endowment. When I was at Google, I had a theoretical budget of $2 billion. And when I was at Skoll itself has got several $1 billion now, but my budget was significant, but much less than that. But none of that came out of the corpus. In the United States, there's trillions of dollars in DAF funds. I think more accurate, it's $1/3 of $1 trillion in DAF funds, and a similar or larger money in foundation corpuses. We should be trying to persuade those who are making decisions about grant making that this is not the time to try to simultaneously increase your foundation corpus and only stick to 5% annual disbursements. This is a time to really realize that we're all in this together, for God's sakes, and let's figure out a way to use all the resources each one of us has at our disposal.
Oh, absolutely. We will have some time in the last few minutes. We're not there yet for questions. What I would ask, if you do have a question for Larry, if you put it in the chat, I'll look through them and choose either my favorite or the one that I think will put Larry on the spot the most. But I guess building off of that, it's not surprising that you're working with AI, given your tech background. But what I find so compelling about your vision for Eviti and the work that you're doing is that it's very clearly coming from your background as a physician and as a public health and global health leader that has inspired this and is also behind a lot of the sort of algorithmic approach to what Eviti is doing. And I think that it's actually a very interesting model for some of the ways in public health technology that we can do well and do good. So, you know, we maybe share a little bit about what you're doing with Eviti, but maybe bias it, if you would, towards kind of why maybe not your background as a technologist is as important as your background as someone who wants to heal the population and the global, you know, society that we live in.
Yeah, I mean, my values are pretty clear: health for all. And that means the poorest and most vulnerable person in the world. And that means working in trying to make a do good, do well company. We're working with a for-profit company that we hope will make a lot of money so it can not have to go after venture capital we don't want. And we have an aligned nonprofit that gets grant money. Everything the nonprofit gets, the research that's done in the nonprofit, that's public domain, free, for everybody. That right now we're starting with the effect of climate change on health, and we've got a grant from the Waverly Street Foundation to build that out. And we're very proud of the work that Matt Willis is doing as our curator for that. On the for-profit side, our theory is that the expert in the loop, the human scientist, is not as fast and not as comprehensive, but wiser than the AI models of today and in the future. I sort of believe that if you ingest the entire internet in order to train and then try to invest it again and then ingest again the work product of your AI, you're committing original sin. And getting rid of those things that may only cause a hallucination once in 100,000 or once in a million times will create suffering. And it's inevitable that it will poison what you're doing. I was interested to see that Apple today announced that they were going to hire doctors for the first time to coach them on health. I just thought that was a novel and interesting idea. So our experts in the loop, our model is in theory trained with a 4-year medical education, including the last 2 years, which are the hardest, and curated when we're done with it by 15 scientists in the top 15 areas that steal years of health span, that contribute to what the actuarials call the health span lifespan gap, but I prefer to call it the sick span. It's gone up from 2 or 3% 100 years ago to 20, 22% in some places today. We live a fifth of our life in that period, and we don't need to. With the right prevention, early detection, rapid response, the things we know from public health, chronic diseases can be dealt with, not like infectious diseases, but use some of the same tools. So we're doing that. We've also got a novel way to look at long-term cohort studies and unpack the wisdom that are learned in, whether it's NHANES or the Harvard Doctors and Nurses Studies or the Norwegian Mothers and Child Study or the Odyssey database, if Sam lets us use it. Though we can unpack the wisdom in those as well and add, and of course, then the individual, the digital twin, the wearables, the genome they got done on the side, and measure the exposome, because the exposome is probably more important than your genome. We understand now your zip code is as important as your genome. And put all that together into a decision support system for physicians, into an individual person's health advisor. But there's I had this conversation with my friend Vinod Khosla, who I love, but as a venture capitalist, I don't want right now, because he said that AI is going to look at the 1.2 million physicians, and when AI is finished with them, they'll probably be only 2.2 million. I don't think we want that. I don't think we want to get rid of the doctors and nurses. I think we want to make them better. So we're doing now CMEs to train doctors and CEs to train nurses and CPEs in the UK to train doctors, and maybe take a look at medical education and bring in the ideas of health span and longevity minus the snake oil. because there's more snake oil than fish oil in today's science of longevity.
Although one of the things that I pointed out to someone is that while there's more snake oil than fish oil, there's also fish oil. The problem is it's just buried in, 10 to the 7 PDFs that are floating around on the internet. And, teasing that out of those is one of the things that AI has really demonstrated a capability for doing. Of course, the AI can hallucinate, but if you're thoughtful about how you put the guardrails up, it can help you find things that we've missed.
100%. And when we get a curator, and I mentioned, and Sam knows this, that our curator for cancer is a Nobel laureate. When we get a curator, that curator is not going to really be able to do the unpacking, find the paragraph that's dispositive in the article, but we build a team around them. And that means we have to build curation tools. So with Sam's help and with Osama's help and with his team, we're building an easy button for curators so that somebody can be old or young or as experienced or not, but they can help curate the science that goes into the model. And because our model doesn't know anything about any of the politicians or about baseball stars or movie stars, but it knows everything about medicine, hopefully that will be a treasure chest that other researchers can use. And we hope that we can help, even if there's institutions on the call. We not only make CMEs, but we make a CME maker, which is a set of tools that will let anybody do the curation, do the annotation, the prioritization, the scoring of what goes into the model, so that you can be sure that the model is being fed the food you want it to have.
I know we're coming up on time, but we have a great question in the chat about sort of what we need to do under the current administration to try to fund public health. But maybe I'll ask a slightly modified version of that, which is one of the things that does seem to be true across large parts of the country and internationally is a lack of or a reduction in trust and faith in public health agencies. What do you think we need to do to rebuild some of that trust?
I mean, tell the truth, be transparent, acknowledge mistakes, and look for those people who have found the talent to communicate it better. Caitlin Jetlina, Baruch Fishoff, people able to communicate public health. One of the things that medical schools do not do is to train you to get on CNN. They do not tell you, how to talk to a group, do a slideshow, or have a pithy statement or anything like that. I mean, it's when you're dealing with people who are cosmetically attuned to being on camera and who are emotionally comfortable with that, trained to do it, and then you have a group of people who are earnest scientists, it's not fair. Media does not favor the scientists in that regard. So tell the truth, be transparent, acknowledge your mistakes, and endeavor to fix them. Bill Foege, my mentor, who was the head of CDC, took me to see my first smallpox case, made a gamble on a 25-year-old kid who had just out of medical school to join WHO. Bill has something called 9lessons.org, the number 9lessons.org. And it's the lessons from smallpox eradication. But he doesn't talk about ring vaccination or use a lyophilized vaccine. He says, number one, with trust, you can do anything. Without it, you can do nothing. And he says, we live in a fact-based world. Well, he may have to put an asterisk on that for a couple of years. We didn't, but we will in the end live in a fact-based world because it's a cause and effect world. That's number 3. Anyway, I think you'd enjoy it. And his 9 lessons are much more articulate than mine.
That was actually one of the things that came out. Larry and I were on a paper that actually John Brownstein's group led out of Boston Children's about mask wearing. And one of the take homes is that, we know masks can slow transmission. We showed that in the paper. But what we showed is that if you want to predict who's going to put a mask on and who isn't, it entirely comes down to whether they indicate that they have trust in the sources that are suggesting to wear the mask. It's not mandates, it's not availability, it's even surprisingly not even accessibility. It's whether or not they trust the sources that are telling them to put the mask on. I think with that, please join me in thanking Dr. Larry Brilliant for spending time with us and for all of his contributions now and what I'm sure will continue in the difficult times that we have ahead of us. This brings us to a close today. Tomorrow, we're going to continue our work in groups to develop answers to the questions that you've all been working on, as well as have our readout sessions. As we mentioned in the opening, the goal for this session is to build on what started this past summer, what Dr. Blumenthal and others have been building for years now, and of course, others like Dr. Brilliant going back decades, to develop a concrete plan for Northeastern and how that fits into the broader ecosystem. And so we so deeply appreciate your time and value all of your contributions, and want you to understand that the time we're also asking for tomorrow is going to contribute to helping us build the kinds of trusted, technology-driven institutions that we must have if we're going to be successful in this new era of distrust in public health. And for me, and I think for many others, it's absolutely existential that we get this right. So thank you all very much. Huge thanks to the KI team and of course to the team from Northeastern and Bouvet that have been working on this, and we will see you all tomorrow.